We believe the future of sensory science lies in collaboration. Whether you're a researcher, creator, CPG innovator, or wellness advocate, we invite you to join us. At the World Taste and Smell Association, we're bridging industries to reimagine the way we sense, connect, and heal. Let's explore new frontiers together. Reach out at hello@tasteandsmell.org or visit us online to learn more.
Good morning, everybody. Good afternoon. Welcome, everybody. Thank you very much for joining us today for a special Parosmia Awareness Day discussion co-hosted by the World Taste and Smell Association and STANA. I'm Stephanie Foyer. I'm the co-founder of the World Taste and Smell Association. A couple of months after I lost my sense of smell in 2017 from a virus, I was up late writing. I smelled something awful, like vomit. I thought it was the hall bathroom. I scrubbed and scrubbed, but the smell didn't go away for days. I knew I had a problem, but information was really hard to find. And just as so many of you have experienced, my primary care doctor was also stumped and less than sympathetic. I'm delighted today that we are joined by several knowledgeable, empathetic, and forward-thinking clinicians, as well as individuals who have experienced parosmia firsthand. But most important today is you. We want to hear your questions and concerns, your coping tips and personal challenges. Please use the Q&A feature for that, and know that we'll have lots of time at the end for an open discussion. I'd like to tell you a little bit about the World Taste and Smell Association. We're a 501c3 nonprofit. We're committed to enhancing the appreciation of our senses of taste and smell and their profound impact on our overall well-being, our mental health, our safety, and our social connectivity. We translate sensory science into real-world impact through education, advocacy, applied research, and events like these, our Delicious for All platform and World Taste and Smell Day. You can find out much more at our website, which is tasteandsmell.org. We're a global alliance of sensory experts, advocates, and innovators committed to advancing the science of taste and smell and its vital role in our quality of life. And we partner with others who are working towards these same goals, which is why I'm particularly delighted today that we're able to work with STANA on this event. Katie Botang, the president of STANA, will tell you a little bit about that organization and introduce our first speakers.
Thank you, Stephanie. So moving forward here, the Smell and Taste Association of North America, we are also a nonprofit based in North America, which started back in early 2020 before the COVID-19 pandemic, but we had coincidental timing. Our goals are to improve the quality of life for people who are dealing with smell and taste dysfunction. I have acquired anosmia due to an upper respiratory infection back in my first year of college, so I have been completely anosmic for about 15 years now. One of our goals at STANA is that we seek to expand research, education, and training on these disorders for everyone in North America. We seek to partner with other organizations, which is, again, to echo what Stephanie said, why we are delighted to be here today, to partner with the World Taste and Smell Association to bring you an event on Parosmia Awareness Day. I want to introduce our patient leaders who are going to be telling you a little bit more about themselves. So I won't go into too many details about each person, but I do have just some small things to say. So please welcome Linda Frantisak. We'll start with her, a dedicated advocate who has lived with smell and taste disorders since 2019. And Linda's going to tell you a little bit more about her personal story and her advocacy. So Linda, over to you.
Thank you. Hi, I'm Linda. The beginning of my parosmia journey started with the common cold virus in the spring, summer of early 2019, and it lasted an unusually long amount of time. This was a year before COVID-19 had started. After a while, I noticed that I couldn't smell or taste anything. I thought this was odd, and then things started to smell strange and taste disgusting. It gave me headaches and made me nauseous. I've never experienced anything like this before. things smelled wrong or the opposite of what they were supposed to smell like. Some of the things would smell like something burning, something rotten or spoiled, garbage, sulfur, sewage, even decaying dead bodies. It's such a strange condition. So many things could trigger this misunderstood condition. Food was the biggest problem. Some foods that I can't stand to eat anymore are peanut butter, chocolate, coffee, citrus, eggs, garlic, onions, anything fried, any greasy food, and most meat. Also, I can't cook or even be in the same environment where food is being cooked, grilled, baked, or fried. Besides foods, there's other triggers like cleaning products like dishwashing soap and laundry detergent. Bath and body products like hand soap, shampoo, lotion, perfume are all terrible. Even toothpaste would smell and taste repulsive. It's very depressing and socially isolating. Shopping and restaurants and going to other people's houses weren't enjoyable anymore. People don't understand because it's so difficult to explain the bizarre odors of this invisible condition. I went to many doctors throughout that summer in 2019. Each doctor had a different diagnosis, but by the end of the summer, a doctor told me not to come back with this problem because there was nothing more they could do, although it should get better on its own with time. So I was given no help, no support, no information, no treatment, no follow-up. How was I supposed to live with this condition? So I looked to the internet for medical advice and found little information there as well. But I did learn that I might have had something called anosmia, which is a smell loss, and later it developed into parosmia, a distorted sense of smell. I didn't even know how to pronounce these words at that time. After COVID started in March of 2020, there were news reports of smell and taste loss by that summer, followed by the same bad smells and tastes that I was living with still. From this frustrating experience, I know how important it is to find help when you need it, when you're living with such a horrible condition. Because of this, there was so little help when I needed it. I designed and launched the Parosmia Awareness website by the end of 2020. I wanted one location where anyone can go to find parosmia information, support resources, maybe some helpful products and tips, or anything else that someone with parosmia will want. Then I declared the first Parosmia Awareness Day on June 27th, 2022, in the hopes that we can continue to acknowledge parosmia annually, where we can advocate for those who are living with parosmia and discuss any research and new developments, and to continue to spread awareness of parosmia so that others can understand this horrible medical condition that impacts so many people's lives in a negative way. It needs to be addressed. Thank you.
Thank you very much, Linda. So now I would like to introduce briefly Pam Flynn, who's the founder of Swirl of Hope, which is a support and advocacy organization for people living with long COVID. And Pam's own journey began after her own COVID-19 infection, so I will let her share her story. Pam, over to you. Oh, 1 second, Pam, you have to unmute.
Got it?
Perfect. Go ahead.
Okay. Hey, my name is Pam Flynn. I founded the website Swirl of Hope to bring awareness and unity to those of us suffering from long COVID-19. One of the most difficult post-COVID conditions is parosmia, which is defined as distortion of smell. Parosmia may be caused by other issues such as sinus infections, head injuries, neurological disorders, and other factors. I'd like to share my story of how parosmia changed my life in a shocking and frightening way. I became sick with COVID-19 in August of 21. Within a week, I lost the ability to taste and smell. I wasn't surprised because I've read so many post-COVID conditions. It made me sad, but I wasn't surprised. I was just hoping it wouldn't be forever. So 2 months later, I woke up one morning, the coffee smell, as you guys understand, repulsive, offensive, and just strange. I realized that I was developing parosmia, a condition I desperately hoped to avoid. Suddenly, everything changed for the worst. Cooking at home became impossible due to the revolting smells, which have been described as foul, rotten, dreadful, revolting, disgusting, offensive, and more. I couldn't go to restaurants because the smells were unbearable. Mashed potatoes, rice, and honey buns, with icing, of course, were my safe foods. Even though I forced myself to eat in a healthy manner, I still lost 60 pounds. I ate healthy to stay alive. I ate fish, grilled fish, veggies, and fruit. I just made myself do it and to get through the roughest of times, and it got me through. But it isn't just the smell of food that is altered by parosmia. Perfume, soap, grass, shampoo, candles, people, pets, toothpaste, air fresheners, even rain. The list goes on, and nothing smelled normal. I tried various methods to restore my sense of smell. These included essential oils. Let's see here: acupuncture, chiropractor, castor oil, neighbor sprays, vitamins, supplements, lion's mane, a smelling kit, steroids, ENT appointments, a TENS unit, a neti pot, antibiotics, an inhaler, and more. However, nothing cured me. I now go back and forth between anosmia and parosmia, which is my new normal. You never know, as you know, from one day to the next. Our social gatherings, as a retired kindergarten teacher who spends a lot of time at the swimming pool, most always involve food. And my friends would often say, "Hey, taste this, it's yummy." Or, "How's your food?" And I thought many times, if I only had a symbol to point to or a t-shirt to indicate without words that I could either not smell or everything smelled horrible. My Swirl of Hope emblem originated from a colorful painting my daughter created over 20 years ago. It represented the light colors of hope, the dark colors of frustration, and the swirl of constant change as we travel this challenging journey of dealing with a silent, invisible disorder. Please visit my website, www.covidswirl, to learn what others are experiencing as they suffer from these life-altering conditions. But on a positive note, there are people being cured from parosmia every day and other long COVID symptoms. So let's don't give up hope. Okay. Thank you.
Thank you very much, Pam. So I will move this forward. And you told us a little bit about your own parosmia stories, both you and Linda, and why you both got involved with starting Parosmia Awareness Day and your websites. So Linda, I'd like to ask you, after all these years of dealing with parosmia, what are some tips that you have that you could tell people that have made things a little bit better for you?
I say try things that are cold. Cold always seems to be better than hot, like cold food, cold drinks, cold maybe coffee, cold iced tea, iced coffees instead of hot tea, hot coffee. Try to add some texture to your food. That seems to help with the mouth feel of the bad flavors in your mouth. Eat fresh foods that are cold, not canned, and not leftovers. It seems that the fresher, the better. I add a lot of sauces and seasonings to cover up the unpleasant taste or the chicken taste, because the chicken will taste like raw spoiled chicken now. So lots of barbecue sauce. Try cinnamon toothpaste instead of mint. There's not many choices in toothpaste. It may sound silly, use a nose clip, because if you can't smell it, you probably can't taste it. Look for sulfate-free products for personal care products, because the sulfates seem to maybe have a problem with interacting with your senses too. Those are a few things, and I have more on my website.
Excellent. Thank you very much, Linda.
Sure.
And Pam, with your website, covidswirl.com, you mentioned earlier to me before the webinar that you have gathered testimonials. So could you just tell people a little bit more about how they can find those testimonials on your website and what they cover?
Yeah, I mean, right on my website at the very top, it says testimonials, and there are so many. And I truly probably have 1,000 testimonials as I've been researching this over the last year or two. And they're just things people really don't believe unless they experience it or they're with somebody that has that. I'm looking at one right now. As a pastry, this is a testimonial. As a pastry chef in Charleston, South Carolina, and recipe developer, I relied on my taste and smell for over a decade to do my job, which I love. Now food smells like what rotting flesh must smell like. I have become mentally, emotionally, and physically exhausted. Every day I break down crying. I'm afraid I'll never be able to do the job that I love so much again. This condition has changed my life for the worst. But also on my website, I try to find success stories to give people hope, after all, it's a swirl of hope, you know. So this is a success story. To my fellow Parosmia warriors, I finally recovered, and I want you to know healing is possible. There was a time I thought I'd never enjoy a smell again, but today I can breathe deeply, smile, and enjoy life again. Please don't give up. Your recovery may be closer than you think. And I love these positive stories because they are out there.
Thank you so much, Pam, for sharing those. And if anyone is interested in learning more, as Pam mentioned, you can go to her website. So I'm going to move it forward and pass it back to Stephanie with the World Taste and Smell Association. Stephanie?
Thank you. So one of the things that, we experience these symptoms, but sometimes it's a little bit hard to understand why. So we've asked Dr. Jonathan Overdevest to demystify some of what's going on. Dr. Overdevest is the head of the Smell and Taste Clinic at Columbia University, New York Presbyterian, and he specializes in surgery and treating patients with rhinological disorders. He's also a professor at the Columbia Medical School and one of the leaders in understanding olfactory loss.
Thank you, Stephanie. And so a bit of a challenging topic to take on today, but we're going to try to break it down in a way that's relatively meaningful and hopefully something that's understandable. But there's so much we don't understand about parosmia, and thus underscoring the importance of why we need to continue scientific investigation into this realm. But what I wanted to try to lay out was a little bit of the background of what can contribute to overall our sense of smell and how that can become oftentimes misinterpreted by our brain or with the signaling processes that allow us to facilitate odors and our processing of them to be able to have that perception of smell. So Stephanie, next slide, please. So what we have here is a depiction. It's an over-enlarged olfactory bulb, but what we can see here are a number of colored dots, and these represent the endings of the olfactory neurons within our nasal cavities. Each of these are color-coded, and they pair with an area within the olfactory bulb that's typically termed the glomeruli. What's important here is that typically there's a single receptor for odor molecules on each nerve, and those nerves then run to their corresponding glomeruli or location that they signal to within the olfactory bulb. And it's this correspondence where it's a one odor molecule to receptor, where that receptor is attached to the neuron that signals to the part of the brain that processes smell, that is really important. And subsequently, those are then processed within the olfactory bulb and distributed to the cortical areas of the brain, as well as other areas that help with odor memory, and overall emotional processing. What happens, sometimes this can get disrupted. And so, Stephanie, next slide. What we can see here is a representation of this a bit further, where those odor receptors are responsible for picking up different types of odors. And so there has been some research in parosmia and individual experiences that vary based on the individual themselves over what foods and what smells can trigger parosmia. Some contexts suggest that there may be an association with different types of odor molecules, and that's what we have outlined here with these molecules that represent ways that we're able to pick up odors and perceptions from the environment. And those are just different catalogs of molecules based on their class of overall structure. And each of these will convey in their formulation a different component of smell. And those are what then bind to the receptors within the nerves in the nose, passing that signal up to the nose and to the brain. There are some different classes of receptors that have been identified, and that's off to the right. And this is an area of ongoing research of whether or not certain afflictions, particularly post-viral olfactory dysfunction, can cause certain classes of these olfactory receptors and olfactory nerves to drop out preferentially. So there are a couple hypotheses, if we go to the next slide, of what could potentially happen. And this is a depiction. So in this case, instead of seeing the color-coded purple, orange, green, and red of the olfactory neurons, we can see on the left the baseline of where we have red and blue neurons, and each of those has the small tendrils that are the axons running into the olfactory bulb. So while these receptors are picking up either the red or blue odor molecules and then correspondingly transmitting that signal to the brain, what can sometimes happen after a viral infection, theoretically based on this hypothesis, is that these neurons get miswired. So if we have loss of those neurons and during the regrowth process, if they plug into the incorrect areas in the olfactory bulb, this can cause cross signaling that prevents the area of reception from mapping the odors appropriately. And so this can occur during the regenerative process. This is the miswiring hypothesis. We also, if we go to the next slide, can consider some dewiring is one way of thinking about this. And this is with excitatory signaling. We can think about this as if a cable, as you can see on the MacBook here, gets frayed. And this is during a demyelination process. So typically these nerves require a sheath to prevent the signal from jumping out aberrantly. There are some that believe that possibly this loss of sheath can contribute to the miswiring or misfiring of the nerve. And so the transmission of the signal isn't going correctly. And so this could be a way of passing or bypassing the correct insertion into the olfactory bulb. We know that this condition occurs in other medical issues such as epilepsy or even multiple sclerosis. And so this is something that potentially could be contributed to why the nerves are misfiring and we have that perception of something that should be a pleasant smell and ultimately perceived as more unpleasant or foul. Another thought is just central misfiring, where overall, if we go to the next slide, that the olfactory bulb and the processing is incorrect. And so while we may be picking up certain signals in the nose and transmitting them appropriately, there may be areas of which we typically process the smells, most likely the entorhinal cortex, as well as parts of the thalamus and various other aspects of the olfactory tract. And those are all areas that are just important in processing and understanding what the odors are. So if those areas in the brain aren't collecting the signal appropriately, that can also cause some problems. And so between these kind of three major hypotheses of the missignaling because of the poor reception and attachment of the odor molecules, whether or not the wires themselves are getting frayed, or there's just a poor perception in the brain in the way that we should be processing these signals, these are all areas of ongoing investigation and trying to understand exactly what is happening, what's occurring on the base level. Now, without a full understanding, we can't provide full interventions that are going to provide relief. But as I think we've heard today, even just some of the adaptive strategies can be very important in how we approach the various ways that we deal with olfactory dysfunction, whether it be from quantitative loss, so decreased signal, or this misperception where things are firing in a way that we wouldn't expect. And so this is some of what we had found in some early research that we had done with our group and has been echoed by others of the different coping strategies. And so we can go to the next slide. There are ways to classify these coping strategies based on approach or avoiding coping. This is based on a validated questionnaire. Approach coping, as it sounds, is one that kind of embraces a problem and tries to find productive ways to deal with this. This isn't always easy. Avoiding coping is ways that we would just try to find other distractions, maybe not necessarily in a productive sense. So rather than finding other activities that can maybe just dissuade us from concentrating on the odors, finding things that kind of take that away. This is sometimes with like smoking or drinking or other habits, as well as other ways of trying to diminish the impact that this has. One of these areas is denial. That can be really self-destructive. While it can be a beneficial strategy up front, ultimately that perpetual denial can be a real challenge for people to deal with as they come to the realization this is not something that's going away immediately. So what we found in our study was that those individuals that just embraced this approach coping mechanism inherently, just happened to be their disposition or their perspective on how they dealt with other aspects and challenges in life, tended to fare better with their overall amount of discomfort and impact on their quality of life, is evaluated by other questionnaires like the QODNS. That was something that we then subsequently found in another component with coping strategies where there can be engagement coping, and Stephanie, next slide, to disengagement. And you can see some of the representations here. And these are different characteristics and categories that we can kind of look at to better understand what type of strategies may or may not be associated with this engagement type approach, where we're facing an issue and coming up with ways to address it, versus a disengagement. And again, this is not easy, but this is the variations that we did find within participants and patients that we worked with in long COVID smell issues. So this is something that we'll get to hear a little bit more about now in the next component of various strategies that we can use to have a productive ability to adapt while we're waiting for additional insights that will provide better intervention and treatment.
Thank you very much, Dr. Overdevest. And now I will move forward and we will swap topics to speaking a little bit further about the psychological aspects of parosmia. So please join me in welcoming Dr. Bernadette Cortese. She's an associate professor and director of clinical trials in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. Dr. Cortese is a distinguished clinical researcher whose work focuses on sensory disorders, including chemosensory dysfunction. She plays a key role in advancing clinical trials that explore the impact of smell and taste disorders on mental health and quality of life, which are very important topics. Her research is helping to shape how we understand and treat conditions like parosmia, especially in the wake of COVID-19. So I will pass it over to you, Dr. Cortese.
Thank you, Katie. I'm so happy to be here today to talk about some of the ways to help cope with parosmia. As Katie just mentioned, I do come from a Department of Psychiatry. So what I'm going to be talking about today are some interventions used primarily for different mental health conditions, but that we believe could also potentially help with reducing the perceived intensity and unpleasantness of odor triggers that are characteristic of parosmia, and maybe also help to mitigate some of the secondary effects like social withdrawal and reduced quality of life. So the first recommendation is to reduce stress and anxiety. And I've listed various methods that are accessible to most everyone. These are interventions that you can do on your own or with the help of an app. There's many apps available in the App Store for both exercise and different types of stress management. The key is to stick with it and make it something you incorporate into your life in a consistent manner. And this recommendation for parosmia is based on over 15 years of our own research, studying the relationship between stress and anxiety and perceived odor intensity and valence. We've published a lot of data in both children and adults showing that people with stress and anxiety disorders, and even healthy people under acute stress, perceive odors as significantly more intense and unpleasant than people not under acute stress or who do not have these mental health conditions. So it's very important for people with parosmia who already perceive certain odors as very intense and unpleasant to reduce the chance that stress and anxiety can exacerbate their odor sensitivity and contribute to these odor triggers. The next recommendation is to prioritize sleep. And what I mean by this is to maintain good sleep hygiene. And what that means is being pretty strict about sleep, including keeping a consistent sleep schedule. So no going to bed and getting up at different times of the day. So it's going to bed, getting up same time each day, even on the weekends. It means associating your bed with sleep. So no reading, watching TV, or being on the phone in bed. It also means that it's not okay to stay in bed if you're having a difficult time falling asleep. So someone who might wake up in the middle of the night and have trouble getting back to sleep shouldn't stay in bed and toss and turn until they fall asleep. The recommendation is actually to get up out of bed, go to a different room, sit quietly in a chair for a short period of time, and then go back to bed and try again. This recommendation for parosmia is based in part on our work in another condition called tinnitus, which most of you have likely heard of. It's an auditory distortion that's often described by its intensity and unpleasantness, similar to how olfactory distortions are described in parosmia. From a clinical perspective, my colleagues and I have studied the bidirectional relationship between complaints of sleep and worsening tinnitus. And our data show that severe tinnitus can both interfere with falling asleep, obviously, because a loud and unpleasant noise in your ear is going to keep you from being able to fall asleep or stay asleep. But we also know that this association can go in the other direction. So showing that our data show that people with tinnitus report a significant worsening after a poor night of sleep. And so although we don't have these data in parosmia yet, we are seeing a trend of where people with worse parosmia do report poor sleep quality. But we don't know about this bidirectional relationship yet, but we do hypothesize that we're going to find something similar to tinnitus, and that there's a real relationship between sleep and the severity of odor distortions. So the next recommendation is to seek social support. And that has many different forms, including today's event, where people living with parosmia have a chance to be heard and validated and to feel less alone. It's also very important to have people close by who can help buffer the negative effects of parosmia. So having a close ally or social network can help reinforce positive behaviors and mitigate the negative ones. These people can listen and empathize, but also push the person with parosmia to engage in adaptive coping strategies and not maladaptive ones like avoidance and substance use. And Dr. Overdeves talked a little bit about that. This recommendation for parosmia is based on all of our olfactory work with post-traumatic stress disorder. And I'm sure everyone on the call today knows what PTSD is, but what you may not know is that it's often associated with very intense and unpleasant odor triggers that elicit strong physical reactions, a lot of fear, avoidance, social withdrawal, and an extreme reduction in quality of life. And there's a lot of published data indicating that social support is a critical and protective factor when it comes to PTSD, and that people with strong social support have much better outcomes and a better quality of life. And so we know that this is going to be very important for parosmia as well. Keeping a daily diary is the next recommendation. So it's pretty clear from talking with people with parosmia, and even the patients on today's call, that they quickly learn their odor triggers and their safe odors. So the daily diary is not so much just having this list of odors that are good and are bad, but really understanding any potential patterns when it comes to being triggered or having a positive odor experience. So when you're keeping a daily diary, many different things can be tracked, like what odor did the triggering? When did it happen? What were you doing at the time? How severe was it? There's many other things that can be tracked, like how well did you sleep the night before? And is something going on that day that caused a lot of stress? So in addition to tracking these negative aspects of parosmia, it's also very important to track the positive ones. So things like, were you able to eat something that you didn't think you could that day? Or did you have a positive odor experience? Did you go a whole day without being triggered? Or were you triggered, but it didn't last as long? Once this is done over the course, once this, daily diary is done over the course of several weeks, certain patterns may start to emerge. Like maybe you'll see that even though you still sometimes get triggered on days you do such and such, you don't rate the severity of those triggers as severe. So this is an example, but the goal here with a daily diary is that it will help you learn something about what we call modifiable risk factors, meaning that you may find something specific in that pattern that you can do or implement to help you alleviate your symptoms. The final recommendation is to practice elements of cognitive behavioral interventions during situations where odor triggers are likely to be experienced or where they are being experienced. And you've already heard about approach coping from Dr. Overdevest, which has many components of cognitive behavioral treatments. But to provide more evidence that this actually works with respect to odor sensitivity, I just want to quickly tell you about a study we conducted several years ago in healthy adult volunteers. This study was about pain tolerance, but we also tested odor sensitivity. So in this study, participants underwent a pain tolerance test that used heat as the painful stimulus. As you can imagine, from what I talked about before with respect to acute stress, we hypothesized that thermal pain or heat pain would increase odor sensitivity. In this study, we were also testing whether a brief cognitive intervention could both increase pain tolerance and reduce odor sensitivity. This brief intervention included coping strategies like reframing that the pain we were delivering wasn't dangerous. They weren't going to be hurt by it or seriously hurt by it. And we also taught them restructuring negative thoughts to positive ones, like this pain is terrible to this pain is tolerable. And also we included some in-the-moment distraction techniques like counting backwards. Results of this study showed that the people who did not receive this brief intervention did not tolerate the heat pain as well, and their odor sensitivity significantly increased from baseline. So there was a pain-related, or if you want to think about it, a stress-related increase in odor sensitivity in this group that didn't receive the intervention. The people who received the brief intervention were able to not only tolerate the heat more, but their odor sensitivity significantly decreased from baseline, meaning the intervention mitigated the pain-induced increase in odor sensitivity. So these findings support the potential of cognitive behavioral strategies in managing odor triggers related to parosmia. And this, we haven't done this in parosmics yet, but this is an area we aim to explore further in individuals with parosmia, with the goal of developing an evidence-based behavioral treatment intervention. And finally, I would always recommend a therapist for anyone struggling with chronic parosmia because of how much of a negative impact it can have on people's lives. And there's a lot of good therapists out there that use evidence-based treatments for conditions that have similar features to parosmia, odor sensitivity being one of them. Many therapists will use these treatments for these other conditions, but if you educate them on what parosmia is and the type of odor sensitivity that you have, I'm sure that they can help develop an appropriate treatment plan for someone with parosmia, even if they've never treated it before. And so definitely seek out that support if needed. And that's what I have.
Thank you so much. That really was fascinating and gives so much hope that our own brains, our own neuroplasticity can help with the healing. I want to switch to Dr. David Rosen, who's going to talk about some of the new treatments and some of the new research that is available. Dr. Rosen is a doctor and associate professor at the Department of Otolaryngology, pardon my pronunciation, head and neck surgery at the Thomas Jefferson University in Philly. He's explored some of the pioneering treatments, including PRP and stellate ganglion blocks, and he's going to talk a little bit about that.
So I've been working on this since I finished my training back in 1997. I happened to be lucky enough to become affiliated with Monell at that point, the Chemosensory Institute. I never thought I would learn as much about taste and smell as I've learned over the past 5 years, because prior to that, you just didn't see very much. And you can go to the next slide. So this is a slide that I stole from my resident, but it kind of gives you an idea of, kind of like the different sides of the spectrum. And the dysosmia or parosmia and olfactory hallucinations like phantom smells. There's a quantitative side of things, which is much easier to, to test: odor identification, discrimination, thresholds, things like that. And then on the left side, you're looking at much more of a qualitative kind of problem. And it's really funny because I did not talk with my colleagues today about any of this, yet tinnitus is something that we found in some of our stellate ganglion patients, that they had underlying tinnitus that went away after their stellate block. So we started to think maybe there's similar mechanisms. And then when you start looking at things, it really becomes kind of clear that there may be some sort of association. There's also a study at one point that looked at olfactory dysfunction and tinnitus. And when they, subtracted out all the factors, it looked like there was an association between those tinnitus patients and the smell dysfunction. And it really was not necessarily related to like anything related to hearing loss, but it was just the tinnitus side of things. So you can go to the next slide. So, COVID-19, basically pre-pandemic, there was about a 5% sort of evidence of parosmia across the board. And some people think it's up to 50% of the patients post-COVID may have parosmia. And I don't want to go into all the theories, but, that there's a CNS theory, and they talk about, basically, different functional things, but then that some people talk about decreased olfactory bulb volume in some parosmia patients. But the thing that stellate ganglion blocks look to, try and treat was this dysautonomia, which again is associated with the PTSD, which is what stellates originally were done for: PTSD, complex regional pain, migraines. So somewhat of a similar kind of mechanistic thing going on. So next slide. So this just kind of explains what a stellate block is, and basically the way that we do our stellate blocks here is we do them CT guided. We also use steroid, because that original study from Korea basically showed benefit to the olfactory threshold, although that mechanistically doesn't make a lot of sense. But they'd used some steroids, so we just kind of did the stellate blocks exactly how they had done them. And again, I explained to patients that you're just rebooting the computer. So it's like when you can't figure out what the heck to do, you unplug it and somehow it figures it out. Can you go to the next slide, please? So this just came out recently, and it basically showed no difference between the control group and the group that got treated with a stellate block. But there's some pitfalls in number sizes and things like that. Their placebos actually did get an injection of saline, so that's kind of not no intervention, because they didn't really talk about, how many of those patients actually got a Horner's, which would mean that you actually are rebooting the nerve on that side. So I think it's interesting to look at that. We need to really find a way to get some better data on how well does this really work. But again, it brings up the whole idea of how do you test for a qualitative disorder with a good quantitative method. And one of the things they're looking at from Manel, which also came up earlier, is the nonverbal scale of how do you describe the parosmia, because that's something that may be helpful. So you can go to the next slide. So this was our study from a couple years ago. You can go to the next slide. So the long and short of it, we didn't really see any differences in their ability to overall smell, but their triggers went down. They had better quality of life, and this was just a post-survey study, and the average time was 7 months. So it seems to be relatively sustained. You go to the next slide. So this kind of goes into a whole other aspect of all this, because it's all very complicated. And I don't think it's any one thing, but neuromodulators like gabapentin, they just presented some more data from when I was at ACHEMS, but basically this study showed like 8 out of their 9 patients got subjective improvement in their parosmia after gabapentin, and that's the neuromodulator medication route is a whole other thing. And then transcranial magnetic stimulation is something that is much more on the behavioral health side of things. But I've had some patients, because long COVID isn't just parosmia, there's a lot of neurocognitive and neuropsych things going on. So many of them would meet criteria for depression anyway. And I've had a few patients that the neurocognitive, the parosmia, it's been sort of subjectively improved with transcranial magnetic stimulation. And then, the other thing that I've also learned after all this, I never really understood that there was this core group of things like peanut butter was almost universally bad, and any kind of nut butters. And people tended to have these things that are all very parosmia inducing. So the question is there some molecular difference between some of these triggers, and how do you figure out what are the triggers? And similar to tinnitus, can you do behavioral retraining? There's a whole bunch of different things that go on, but the last thing that I'll tell you is that my patients that have parosmia say they would rather go back to being completely anosmic because the parosmia was way worse than being blank. So that's what I have.
Fascinating, though I have to admit that I was one of those patients that was not helped by gabapentin. And
I would agree that the other thing that was interesting at the meeting, the patient did better with lower doses, oddly, for the gabapentin. So I don't know if it's a dose issue, or maybe gabapentin is not the right neuromodulator, but I think that it was interesting to me that the patients with lower doses got better improvement, which I'm not sure what the mechanism would be of that.
Well, like Pam, thank you so much. And thank you all. Like Pam was talking about at the beginning, when she read the list of things that she tried, I suspect that so many of the people who are with us today have tried any number of things. And one of the questions that we have in the Q&A is, how do we suggest some of these treatments to our own ENT doctors, like gabapentin? How would you start a conversation, particularly knowing that some ENTs are not that well trained on some of these disorders? Dr. Overdevest, I think maybe this one is for you.
Yeah, Dr. Rose and I could probably talk on this. I think the benefits are just the increased awareness that's come about. And this is one of the silver linings in overall the prevalence of post-COVID olfactory dysfunction, that I think at least there's awareness amongst the community of practitioners that this does exist. So there's that initial acknowledgement that's important. And then a better understanding of some of the community and network for which they can then provide to the patients, where patients may be able to get additional insight and access to providers who are either pursuing research in these areas, or at least abreast of the research that's going on in these areas and willing to potentially provide interventional therapies. I think where things may become a little bit challenging there is, even if we are aware, it may not necessarily be something that we recommend on a regular basis to some of our patients. So some of these interventions that haven't been fully demonstrated would be some of which we've kind of gone over today: stellate ganglion block, where there's ongoing investigation; gabapentin, PRP is another one where there's ongoing investigation. I say that just because it's important for us to want to pursue some of these treatments, but also realize some of the limitations that may exist. There was just a meta-analysis that came out looking at PRP in the use of this medication or this intervention for osteoarthritis. And ultimately that meta-analysis showed there was really no benefit. And again, this is not for olfactory dysfunction, but this is for more of an osteoarthritic picture using multiple large-scale studies showing that there really was minimal benefit. Those are the type of studies that we need in the olfactory world to be able to support the use of some of these interventions. That's not to say that people can't pursue them as an investigational method, but just understanding some of the limitations. And I think that's probably clear within this community, as Stephanie brought up. She had pursued gabapentin. Generally speaking, it's well tolerated and minimal side effects. And if that's something that people would want to pursue, knowing the risk and benefits, that at least is an option, and they can be afforded that.
So one of the things we talked about when, I don't know if you're the ACAM's meeting, but there's a pre-meeting talking about, like, most ENT residents have no idea about treating parosmia. Like, we don't do a great job of educating our trainees, and we talked about making some of those modules up so that at least there's some resources for our ENT residents to get some exposure, because prior to COVID, there was like zero. So I think that we need to do a better job of educating our own, and also maybe, having these centers of excellence around the country that at least they would know, hey, you're in Manhattan, you're in, Cleveland, and, find a better way for at least our people to recognize it and at least send them to people that are more able to treat the patients than the general otolaryngologist. I mean, I've had patients come in and say, my doctor just said, oh, take some Zofran. And I basically tried to explain, it's not nausea, it's not Zofran that's going to help me. But the majority of the world thinks that it's just makes you sick to your stomach, but it's not just that, as many of you can probably speak to.
Another question that has been raised is, has it been definitively established that the post-COVID disorder is solely parosmia, or are there concurrent phantosmia, that olfactory hallucinations? How might we differentiate those as the underlying mechanisms that could be quite different? And I'm going to add to that a second question, which is there a subjective smell test for parosmia? How can clinicians test for it? What are the challenges around testing for parosmia?
I mean, there really isn't any well-established quantitative testing for, parosmia. And my anecdotal experience is that more patients complain of parosmia than the phantosmia, which is there's no odor stimulus that triggers it. But you could also argue that maybe we don't know what that odor stimulus might have been that created that phantosmia. And it's very, very much associated. Many of the patients have decreased overall ability to smell. And it's almost, to me, rarely if they don't have some at least underlying like hyposmia. I don't know, Jonathan, if you got anything more to.
I would add, I've read a recent paper by Thomas Hummel's group in Germany. They are trying to develop a test for parosmia. It is based on the sniff and sticks, and they use both pleasant and unpleasant odor triggers as, and they compare them. So they pair different odors together and then get some type of score. I don't know exactly how it's being used yet. There's just one paper out on it, but it may become a test that's more widely used in the future. I think it would be a good idea to be able to get a score and to be able to talk to people with parosmia and say, well, you score pretty low on this, or you score very high, and these are the different strategies we may implement depending on those scores. We do the same thing with just the regular sniff and sticks and odor identification, odor detection and threshold. There are different strategies of what and basically gives us an idea of what the deficit truly is. Different mechanisms at play when it comes to those different subscale tests.
Yeah. So Bernadette, what you're referring to, I think, is the SS Parrot basically using valence. So valence is the way we think about pleasantness or unpleasantness of a scent. Nancy Ralston's on here, and she's asked some questions, which I think she's also probably can answer better than some of us. She is a leading expert in olfaction at Monell, but she also highlights, and I was going to bring this up, that one of the products that has been developed in partnership and disclosure with at Monell, but the Sentinel product is able to differentiate parosmia. The other components are just really teasing into the clinical history. So understanding through some of the quality of life questions of whether or not it's a characteristic qualitative dysfunction. For example, do you feel that your sense of smell is more impaired because you have a distorted smell that is more prevalent or more prominent than your loss of smell? And then, as Dr. Rosen pointed out, I think what we've seen in terms of post-viral olfactory dysfunction, typically it's this loss of smell that occurs. And then as the sense of smell starts to recover, even though parosmia in prior studies has been suggested as a good prognostic factor, saying, oh, you have parosmia, that's a good thing, your sense of smell is coming back. It's not really necessarily prognostically beneficial. It's simply saying that going from a state where you could not pick up any odorants, those odorants that you're now picking up are a little bit miswired, and things are being conveyed in a way that can be distorted and really unpleasant, and therefore quite repulsive and intrusive. And so that process does occur. There is a component of phantosmia as well. It seems to be much less prevalent and overall in this recovery process. But the phantosmia is more of a smell when no one else is smelling something. So there's no presentation of an odor molecule. You're not eating a food and perceiving the flavor as foul. It's simply, if I were sitting in my office right now and to pick up a sense of smell that really has not been introduced into my environment, that's a phantosmia. I had an interesting clinical case recently where we kind of know this can come about, but they really had no identifiable reason to have any sinus disease. When I looked with a nasal endoscopy, everything looked really clean, healthy mucosa, really no history of any dental issues. And then part of this, because of some other symptoms they were having, we pursued an MRI. And on that MRI, we were able to identify what's a silent sinus. So basically where there was an obstruction and likely some mucus that would build up there. And the intermittent presentation of their phantosmia would potentially coincide with this. So there are sometimes physiologic issues that can result from this. And that's where it's really important just to get engaged with the clinician that's going to be able to work through the processes and kind of tease out some of the nuances that can contribute to this. But there's a lot going on, and I definitely would refer. I know Dr. Rose has brought this up, and kind of checking out everything that Monell is doing as one of the leading research institutes in the country, and been doing this for a long time. They have some fantastic resources as well as some fantastic researchers that are there.
Just to speak to Monell again, they are also working on. We need patients with straight parosmia, that a nonverbal method for quantifying olfactory perception in sensory disorders. So, that's really trying to find some way to quantify this. But again, it's very similar to tinnitus. It's hard to quantify tinnitus. It's hard to, it's these things that require neuromodulation, and it's hard to test it.
Speaking of resources, there is a question. What is the best way to stay up to date on research and treatments? And are any of today's experts have any clinical trials? So I do want to say that on the World Taste and Smell Association website, tasteandsmell.org, we do have a directory of smell and taste centers. And if there's a center that is not there that you know of, please let us know, because we'd love to increase that. And I also, part of the question is about open clinical trials, and there are some experts on the call today who may be working on some clinical trials. So if anybody wants to share that either in the chat or speak up about some of their ongoing research, we would welcome that as well.
I can talk about our Scent for Long COVID study. We're recruiting post-COVID smell loss, and we recruit anosmics, hyposmics, and parosmics. The intervention is smell training and also trigeminal nerve stimulation, which we've used previously to show increased sensitivity to odors after 30 minutes of trigeminal nerve stimulation. So that arm of the treatment applies TNS for 30 minutes and then does their smell training. Even though I'm blind to treatment, so I can't talk about it at this point, but my sense is this would not be beneficial to people with parosmia. We're not trying, there's evidence that they already are more sensitive to their odor triggers. They can detect those odors at lower concentrations. So we wouldn't necessarily want to increase odor sensitivity in parosmics. I do believe that these treatment interventions we may find that they're helpful for anosmia and hyposmia. Somewhere we're going to go in the future, and we've proposed a study and submitted it to NIH for funding. We'll see what happens. Is another type of non-invasive brain stimulation that uses ultrasound, and that actually doesn't just stimulate, the nerves in the face, the trigeminal branches, but it actually can stimulate deeper regions of the brain. And we are targeting a specific region that in animal work has shown is involved in odor valence. And that is targeting two regions, or the connection between the amygdala and the ventral striatum. And so with this non-invasive ultrasound technology, we're able to go and apply stimulation to either activate that area or deactivate that area, in a sense, and see our preliminary data in healthies showed that we can improve self-report of odor valence. So odors were rated as more positive after we applied this stimulation. We'll see where this goes. It's quite expensive to run these types of studies, so we would need full funding for them to pursue it in the future. But that's our aim, is not only behavioral interventions, but also non-invasive brain stimulation techniques. And there's many out there that we use in psychiatry pretty regularly.
I echo that. I think that those, non-invasive treatments are things that are going to probably end up being very helpful. And I think partnering with behavioral health is incredibly important for both parosmia and tinnitus. And thank you for all of your work.
I think that does highlight one of the important aspects. These studies, even though they seem relatively simple, are extraordinarily resource intensive. So to be able to support the personnel to do the study appropriately so that we can get results that are applicable and distributable in ways that we're going to actually be able to rely on them for their validity, it requires careful attention to the study design and overall the implementation. And this is a major issue going on at the national level at the moment. Even our friends at the NIH and all the work that's being done there have come into a bit of a crisis with some of the recent changes. So not to kind of distort this into any type of political component, but financial support and supporting these grants that go in that are overall evaluated by other experts and are at a competitive basis to be able to be funded, to be able to provide these therapies and to evaluate them for their utility, are right now not necessarily moving forward in the way that they should. And so that can be an ongoing challenge. But I think that there are glimmers of hope, and there are other alternate pathways that are coming about. And that's in collaboration with organizations like STANA, like WTSA, other groups in the UK, whether it's Fifth Sense or Chrissy Kelly's group, CKOS. These are all organizations that are kind of on the front line and can serve as a good interface between patients and those patients that are interested in being participants, and the providers and clinical trialists that are putting together some of these studies. So there are always things going on. And if nothing else works, just reach out directly. I mean, we always try to answer as much as we can via email. And there are studies that are coming up. Like right now, we're going to be enrolling for a study looking at some of the transcriptional changes in individuals that have persistent smell loss. And so it's not always that you may qualify for a study, even though you have certain characteristics, but those are things that we can look at and evaluate and help you get to the right place.
A couple of quick questions. Peanut butter was mentioned as a contributor to parosmia. Are peanuts suspected in a similar manner?
In general, it's tough. There's been some work looking at the molecular basis for parosmia and identifying certain foods and some of the molecules that are most prominent in those foods and how they can drive parosmia. And that's some work out of the UK with Jane. So I would imagine, there would be that overlap. I think certain times when we have processing, peanut butter tends to be something that's more universally consumed. And because that is more reported anecdotally on message boards and various other pathways that patients are interacting and having reports for their parosmia. But as long as they would be the same molecules represented, based on that study, there would be some support of that. We know that it's not all just a chemical process. That study suggests that there is a contribution, but the triggering aspects of certain odors are not simply due to the molecular compound.
And even patients have complained about other nut butters because the biggest problem for these patients with parosmia is getting enough protein, period. Because many of the things that are savory are not very pleasant when they're distorted. And peanut butter used to always be a go-to for people unless you're in a peanut-free school, but they struggle, and they tried like nut butter, walnut butter, almond butters, and maybe something related to just the nature of like tree nuts. But I don't know that we have enough true data to explain it one way or the other.
I have a
And
problem with peanut butter and peanuts, but I can do almonds. I do a lot of different things with almonds that help. But I do have a lot of problems with protein. I eat a lot of too many carbohydrates, too much sugar, because I can taste the sugar, I can taste the salt.
Yep.
Very bad diet.
another question was about garlic and onion, which also in the Jane Parker study that was referenced came up as molecules that may well be triggering. And I think Linda and Pam both can attest that that's something that they've heard that many people with parosmia also have trouble with. Another question in the chat is about MS and Sjogren's syndrome and whether parosmia and anosmia are linked to that. Could one of the medical professionals speak to that?
Yeah, so this is an area where there have been some limited studies in the past looking at various autoimmune issues and their association. So like systemic lupus erythematous, or SLE, can sometimes be associated with smell loss. And there are some limited studies in populations, but it's not something that's been broadly understood. So there are components, and that also ties in with some of the things that we think are occurring in the post-viral sense, where it's not necessarily destruction of our overall nasal machinery that allows for sense of smell, but it's a subsequent dysregulation of our body's response to the virus that ultimately results in smell changes. And we know with autoimmune disorders, that's essentially what's happening. It's the body's innate and adaptive immune system is responding against the trigger, but then that sometimes gets cross-triggered with some of the natural, more commonly occurring cells in the body. And so that can potentially be associated. But to answer the question directly, there's not many studies that have a direct correlation, but we know that these can affect, particularly with MS, with the relapsing and remitting components, you can have components of the olfactory pathways that can be affected in these situations.
A related question about whether or not there is underreporting in the problem of parosmia. Says, I would have never thought that patients might struggle with denial. In addition to providers not being well trained in treating smell disorders, or perhaps even identifying it, how much is underreporting a problem in terms of developing greater levels of awareness or petitioning for much research funding? And I know this is an area close to where we are at the World Taste and Smell Association. And there was a recent study from UC Irvine associating 139 different disorders with smell loss. But would you want to comment a little bit about the underreporting or the likely prevalence of smell loss and distortions in the population?
I would just say that prevalence rates range from 10% all the way up to 75%, depending on what study you read and how the olfactory dysfunction was measured. And so right now, I don't think we have a good sense of what the prevalence rate is. And I would agree that it's likely that it's underreported. I think if we were able to go and test everyone, we would be able to get a true sense of this. But
And again, with the lack of a reliable test, I think also probably leads to underreporting because it's difficult to quantify it.
A question specifically about COVID. Is COVID the first virus type on such a large-scale basis that has been implicated in these curious olfactory disorders? And has anyone mapped how long it takes patients to restore sense of smell after COVID infection? Is there a curve?
Yeah, so I guess just taking both those briefly. So there are essentially a number of studies out there in different ways that they were designed to try to get a better bead on what the recovery curve would be. A lot of those studies, and even some of the meta-analyses or compilation of studies, use mostly subjective reporting, and that can be limiting in certain ways. We know that most individuals understand that they've had some change in their sense of smell and are able to report that out, but it's not as if we can track that as well quantitatively or put that to a level of understanding within the normative population to see kind of how their scores would be. And that's where psychophysical testing and kind of just doing regular evaluation, similar to what we do for hearing assessments, can be beneficial. And so a broad understanding of that hasn't really been available. But that's a study that we have coming out looking at that on a number of levels for participants across numerous studies that we've looked at their psychophysical testing and their reporting of results to see their recovery curves. So that is available. I think in general, the answer to the question about viruses, a number of viruses can cause olfactory dysfunction. I don't think that there had been the same onset where a large portion of the population suffered the same symptoms at that time. And so, or the degree that it was caused by some of the varying strains, particularly the early strains of SARS-CoV-2. And so it's that acute onset at a similar time, at a similar moment where this was able to be reported out. That really led to the culmination. But even beyond SARS-CoV-2, we see a number of patients on a regular basis, even this year, that were diagnosed on viral panels with parainfluenza, influenza, sometimes even just endemic coronavirus that existed before SARS-CoV-2.
yeah, so one question that keeps floating around my brain is if COVID somehow changed the relationship between a virus and losing our sense of smell, and now other viruses have a greater potential of causing that symptom. Do you have any sense of that? Do you know what I mean?
Yeah.
I don't know if I asked that question properly, but
I think heightened awareness is
it's just heightened awareness.
and because now all of a sudden taste and smell has come out of the closet in the place where almost nobody really paid much attention to it, to now it was all over the place. And then I think as the strains and the COVID strains are changing and morphing, the nature of the smell loss is also changing. So I think those, originals and Delta variants were by far the majority of these patients. And, you still do get new patients with, new onset, smell loss from COVID, but you also just don't know if it's that I'm seeing them more quickly now because I don't have such a huge backlog. But I would say that before COVID, there really was never this much interest, and I think that's one of the only sort of pluses is now I think people are more likely to be aware of it, maybe more likely to get treated.
Quick question for you, Dr. Rosen. Has anosmia ever been helped by the stellate block?
Well, it's a tricky question because the placebo trial just said stellates do absolutely nothing. In our data, their overall ability to detect odors hasn't changed, but that Korean study back from 2003, pre-COVID, they seem to have some improvement in the overall smell scores, but mechanistically, I think that the only way that you might get an improvement in your ability to smell is that taking away some of the distortions may make it easier for you to perceive some of the odors that maybe you were not able to identify previously.
Another medical question. Since my parosmia started, I feel like my tongue is coated, even though it isn't. Is that a common symptom?
David, I may let you
Yeah,
handle.
fine. I'll
I gotta
take
run the clinic.
it.
It's not super common in this direct association. There are other oral issues that come up. I think the big commonality here that we really try to tease out with patients is the importance of smell, the importance of taste, and the coalescence that create flavor. And
Yep.
there are other components that make that more nuanced with chemesthesis and the perception of something that may be effervescent, something that may be astringent, something that may be a bit spicy. All those go into the way that we perceive foods. But that tactile response of your tongue is likely a little bit more of either a separate condition or can be the way that our body is working through that chemesthesis where the tongue feels heavy or dull. So that's what I can offer. And then David, hopefully you can pick up.
Yeah. So
Thank you guys.
Thank you.
So there have been some patients that have gotten the so-called like COVID tongue, where the tongue gets kind of swollen and raw and inflamed. If in the absence of that, you usually, typically people come in and say, I can't taste. And it's a really struggle sometimes to explain the difference between taste and flavor, and sweet, sour, salty, bitter, umami versus cherry, grape, strawberry. So the tongue most of the time is relatively normal. I don't know whether the tongue being white and coated could be like from some, nasal obstruction left over, or some xerostomia, or there's a bunch of different things, but certainly most ENT guys can figure out if there's anything going on actively with your tongue. You have to look for things like thrush and treatable disorders that may make your tongue look white and coated, but you can get sort of issues, allergic issues, things like that, that will make the tongue kind of look weird but feel normal.
I'd love to talk about resources for a moment. We have a resource slide, but specifically, Bernadette, you mentioned a diary and keeping a diary as a useful tool. Are there some available diaries that you would recommend, or some tactics that you would talk about to people who might want to try that?
Typically, we do develop our own study-specific diaries or treatment-specific diaries, depending on what the indication is. But I do think ones that are developed for PTSD could be useful for parosmia and odor triggers. And I think I wrote one in the chat. You can buy one on Amazon.
A PTSD journal by Gerda Wagner. Is that the one that you recommend?
Yes. Yeah, so that's on Amazon. If anyone wants to look it up, I would say that would be a good place to start.
Excellent. So the good news is that we do have some resources in development that are working to test smell, because without a baseline of understanding of what each individual smell is, ability to smell is, it's very hard to then track the changes as well. Are there any other questions that people would like to ask, or anything that anybody would like to share about them coping with parosmia? Any tips they might have as well for others? Please put it in the Q&A.
Hey, I'm trying to ask a question. You see me?
Go ahead.
I didn't mention this when I was listing the many things I tried desperately at the beginning of this, but I did have several stellate ganglion shots at different places, and immediately ran to a fast food place, couldn't wait to taste everything, but it didn't work, which is okay. And at that time, it was almost like a controversial procedure, so that was 2 or 3 years ago. and I'm hoping things have improved in the success stories. But one question I need to ask y'all, okay, so this has been like 4 years. One time I went to a real Chinese acupuncturist, like the real deal. She worked with me one time. I had anosmia, so I walked in the house, and my husband, who never ever cooks, was cooking hot dogs of all things, and I could smell them perfectly. I tasted them perfectly within an hour, way back. And that's the only time that's ever happened. What do you think triggered maybe with the acupuncture that it had to be that, because it was 30 minutes after the acupuncture? Anybody?
Well, so in general, like having treated a whole bunch of people with PRP, which it's a whole other can of worms. It's not really a parosmia play, but um, I find that patients will get little bursts or little whiffs of things, and it may very well be that you have a limited number of neurons and they saturated, and maybe the acupuncture stimulated a few new neurons, but the bottom line, it wasn't sustainable. And I've had the same experience with certain patients getting some intermittent results from acupuncture, and generally from someone that is trained in Chinese medicine, not just somebody that took an acupuncture course. But yeah, I think a lot of my patients will get these little bursts, and you hope that you can keep building on those. But to me, it's at least some positive sign that if you maybe have a few neurons there that were able to sort of fire at the appropriate time. But the bottom line is you really need a lot of them so that you never fatigue, because most people can sit and you put a lavender candle in a room, you're never going to stop smelling lavender. Whereas people that have underlying hyposmia, they're going to eventually saturate, and then they're going to need to recycle. So I think that saturation issue comes into play with a fair amount of patients.
Thank you very much.
A related and last question. Is there any time element to healing?
Our data, as far as like the hyposmia patients, I don't know about the parosmia as well, as far as like time frame, but patients that get treated within 2 years do better than people that are treated greater than 2 years, and then less than 1 year is better than less than 2 years. But I've had patients respond 4 or 5 years out. So, I have a philosophy that if the treatment doesn't harm you and there's enough decent data to show that it may help you, then there's very little downside in giving things a try, as long as you go into the treatment knowing that it may or may not help. But certainly, I don't think any of the interventions I've done have ever made people worse, per se. So as long as I know that I'm not going to do any harm, I'm usually pretty liberal to treat. So that's just my personal sort of philosophy.
And the smell training data is similar to that, is that they think it works better in people with more recent loss. But also, it's a very long treatment intervention. So people really have to stick with it a good 6 months. I think, and a lot of people do try smell training, but not in the way that it really needs to be done. And so,
High frustration factor with all of this.
yeah.
Patients get very frustrated, and I don't think that, again, like I've never seen so many patients as I have recently, but the level of their impact on their daily life is horrible. And until you start taking care of a few of these patients, I think most clinicians don't even have a clue, not even close, to how horribly bad it can be for people with smell distortions.
Well, I want to thank you all for your empathy and understanding and knowledge, and sharing it with everybody who has joined us today. So many who have suffered from just what we're talking about now. And a special thank you to STANA for co-hosting this with us. And Katie, please visit our respective organizations to find out more. Reach out with your questions, concerns, and join us for further events in the future. Thank you very much for joining us today.
Thanks, everybody.
Did you know 1 in 3 people will experience taste or smell loss in their lifetime? Whether it's long COVID, aging, or something you can't explain, you're not alone. The World Taste and Smell Association wants to hear from you. Share your experience at tasteandsmell.org. Your voice can help fuel vital research and raise awareness for this invisible health crisis. Let's stop the silence. Take the survey today at tasteandsmell.org.